Hey guys, welcome back to my channel, The ENT Resident. Today, our topic of discussion is abscesses in relation to the mastoid. Now, this is a very important topic. This can come as a lot of Viva questions or even in NEET PG as your MCQ questions. And this is very important because this is a part of the complications of CSOM that you need to know about. You can also now purchase my notes. I have added links in the description. So let's get started with our topic. Now, what are the different abscesses that we can see in relation to the mastoid? There are 6 such abscesses. The most common one is a postauricular abscess. You can see in the image over here, this is a postauricular abscess which develops behind the pinna. Second is a zygomatic abscess which develops in front and above of the pinna at the root of the zygoma. Third is Bezold's abscess right over here in the upper part of the neck. Fourth is Luck's abscess, also known as the Meatal abscess, which develops in the external auditory canal. Fifth is Citelli's abscess. If you see in the second image over here, Citelli's abscess develops more towards the occipital area. And lastly, there can also be a parapharyngeal or retropharyngeal abscess. So these are the 6 abscesses that we need to know about. Let's get started with postauricular abscess. So postauricular abscess, as you have seen in the image over here, it develops in the postauricular region. So it is a collection of pus in the postauricular region, usually as a complication of acute mastoiditis. And this is the most common abscess in relation to mastoid that we know. Coming to the etiopathogenesis, the most common cause here is acute mastoiditis. So once acute mastoiditis develops, there is a spread of infection from middle ear to the mastoid air cells, which leads to the breakdown of the mastoid cortex, and the pus then tracks into the postauricular soft tissue, leading to the development of postauricular abscess. So that is how the postauricular abscess forms. Now, what will the patient present to you with? First of all, coming to general symptoms first, patient was going to be irritable, in agony, and appear flushed. There will be a case of mild fever and a slight rise in the pulse rate. It is important to remember here that if there is a case where you see a sudden and unexplained fall in pulse rate, meaning a sudden bradycardia in a patient without a corresponding fall in temperature of the patient, it will definitely indicate towards a intracranial complication. So that is something you need to be aware of in a case of CSOM or cholesteatoma. Now that we have talked about the general features, let's talk about what we'll find in the ear. First of all, we'll see that the pinna has been displaced forwards, outwards, and downwards. If you see in the first image over here, you can see that the pinna has been displaced forwards, outwards, and downwards. Next, let's come to the postoral area. We see that there is a swelling behind the ear. You can see how it is red and it also will have a warmth to the area. There is an obliteration of the postauricular groove, and it also has this ironed out appearance of the mastoid. Ironed out appearance of mastoid meaning usually if you try to feel your own mastoid, palpate it, you'll feel that it feels a little rugged, like as if there are some ridges. In case of mastoiditis, however, we see that when you palpate it, it has this very smoothened out appearance, and that happens because of the underlying periostitis. So, this is a typical feature that we'll see here, which is ironed out appearance of mastoid. And there is tenderness when you press in the center and the tip of mastoid. And the skin that you see over here, over the mastoid process, that will be fluctuant. Sometimes the abscess may also rupture spontaneously to drain out through the skin. So these are all the findings in the post-oral area. Now let's move on to the external auditory canal. Here we'll see the presence of mucopurulent ear discharge. And once you have suctioned out and cleaned the mucopurulent discharge, we'll see, as you can see in the second image over here with the yellow arrow, we'll see there is a severe edema of the external auditory canal with sagging of the posterior superior canal wall. This happens because of the thickening of periosteum of the meatal wall. Okay, next is the tympanic membrane. Once you're able to see the tympanic membrane, you'll see that it is congested and there is a central perforation in the tympanic membrane. When you perform tuning fork tests, we'll see tests which are representative of a conductive hearing loss on the affected side. So these are all the clinical features in a case of postauricular abscess. Now coming to investigations, we'll see that there will be a raised total count and differential count. If you see pus, we'll send it for culture and sensitivity and start on IV antibiotics. You can perform an X-ray mastoid of Law's view or Schuller's view. You can also get a HRCT of temporal bone, where you'll see an erosion of the bony cortex of mastoid, which is a typical feature here, and a subperiosteal fluid collection. MRI is done only when you are suspecting any kind of intracranial complication. And lastly, you can also perform a pure tone audiogram, which will show you a conductive hearing loss. Now, all cases of postauricular abscess have to be treated with, first of all, they need to be immediately hospitalized. After that, you start them on IV antibiotics. Drug of choice over here is ceftriaxone. Other options include levofloxacin, moxifloxacin, amoxicillin, and clavulinate, etc. Also, you start the patients on analgesics. Usually, you can give injectable acetaminophen. Daily oral dilating is performed. You perform an incision and drainage only when the abscess is well formed. Otherwise, it is not required. It may subside with IV antibiotics as well. Myringotomy is indicated if this has followed a case of acute otitis media and you see that the tympanic membrane is bulging. In that case, you perform a myringotomy and a Grommet insertion if required. Last treatment method is performing a cortical mastoidectomy. Now, the indications of cortical mastoidectomy in postauricular abscess are if it is not responding to medical treatment after, say, 48 to 72 hours of adequate antibiotic treatment, or if there is any impending complications, or if a case of postauricular abscess has come to you with already present complications. So, that is how we'll treat postauricular abscess. Next, let's move on to a second abscess. Now, this is zygomatic abscess. Now, zygomatic abscess is when there is a collection of pus in the temporal fossa over the zygomatic arch and occurring as a complication of acute mastoiditis due to spread of infection through the root of zygoma. Now, cause over here is the same. It is usually happening after acute mastoiditis, common in children. Now, what happens is zygomatic abscess is most likely to develop when the zygoma is extensively pneumatized. If you remember when I discussed petrositis, that was also the case over here, where if the petrous apex is pneumatized, it has more chances of developing petrositis. Same over here. So, when the infection of the mastoid spreads forward to involve the zygomatic cells, next, what happens is there is an erosion through the cortical bone at zygoma, and that leads to the development of zygomatic abscess. Next, let's talk about how will this patient present to you with. If you see in the image on the right side, the first image is the frontal view of a zygomatic abscess and the second one is a lateral view. You can see that there is a swelling which develops above and in front of the pinna. And the upper half of the pinna is usually displaced. You can also find associated edema of upper eyelid in these cases. Sometimes the abscess can erode at the root of zygoma and enter into the mandibular fossa. In that case, the patient will have a painful trismus. Trismus meaning there is a difficulty in opening the mouth. So the pus in this case, it collects either superficial or deep to the temporalis muscle which lies in the temporalis fossa. So these are the features that you see on the face. Other than this, the common features to all the other abscesses here are mucopurulent discharge in the external auditory canal and tympanic membrane will be congested with a central perforation. On investigating, you will see that the total count and the differential count is raised. You can perform a pus for culture sensitivity, X-ray mastoid. HRCT temporal bone will reveal mastoiditis with extension into the zygomatic root and a soft tissue swelling. And when you perform a pure tone audiometry, it will show a conductive hearing loss. So it is important to remember here that zygomatic abscess forms above and in front of the pinna. Now, how will we treat? First of all, we'll hospitalize the patient and start them on IV antibiotics, analgesics, perform daily oral toileting. We'll perform an incision and drainage only when the abscess is fluctuant, and cortical mastoidectomy is done to remove the infected mastoid and zygomatic air cells. And a very common differential diagnosis of a case of zygomatic abscess is parotid abscess because of its similarity in location. So this is about zygomatic abscess. Third one is known as Bezold's abscess. Now, what is Bezold's abscess? Bezold's abscess is a deep neck abscess that occurs when the pus from acute mastoiditis erodes the medial aspect of the mastoid bone. If you see in the image over here, the second image, this is the mastoid bone, the mastoid tip. When you see that there has been erosion in the medial aspect of the mastoid tip, it then starts tracking along the sternocleidomastoid muscle. And that's how it forms the Bezold's abscess. So, coming to etiology of it, it is usually a complication of acute coalescent mastoiditis and seen when the pus breaks through the mastoid tip and starts to spread inferomedially. Next, what are the possible pathways of spread over here? So, first of all, the most common one over here is it can lie deep to the sternomastoid muscle, pushing the muscle outwards. This is the most common pathway of spread and the most common presentation you will be seeing here. Secondly, it can also follow, if you see in the first image over here, this is the posterior belly of digastric. The pus can also follow the posterior belly of digastric and present as a swelling between the tip of mastoid and the angle of the jaw. Third, it can be present in the upper part of the posterior triangle. Fourth, it can end up reaching the parapharyngeal space. And fifth, it can also track down along the carotid vessels. So these are the 5 pathways of spread once this abscess has developed. The most common one being lying deep to the sternocleidomastoid muscle. Now, the patient in this case will present to you with a sudden onset of a painful tender swelling in the upper part of the neck deep to the sternocleidomastoid muscle. If you see, this is an image showing a case of Bezold's abscess. You can see that there is a swelling over here in the upper part of the neck deep to the sternocleidomastoid muscle. The patient will have restricted neck movement, which is also known as torticollis. They'll also have fever and give a history of purulent otorrhea. And the neck in this case will be bent to the side of diseased ear due to the presence of torticollis. ESC will have mucopurulent discharge and TM will be congested and there will be a central perforation. How do we investigate the case? There will be a raised total count and differential count, pus for culture sensitivity, and on performing a CT scan of the temporal bone as well as the neck, we'll see the presence of mastoid erosion and a deep neck abscess. Now, how do we treat this case? As usual, just like all the other cases of abscesses, we'll be immediately hospitalizing the patient, starting them on IV antibiotics, analgesics, daily oral toileting. We'll perform a drainage of the neck abscess through a separate incision and put a drain in the dependent part. And lastly, we'll perform a cortical mastoidectomy for the coalescent mastoiditis and carefully explore the tip of the mastoid for a fistulous opening into the soft tissues of the neck. Now, there's a number of multiple differential diagnoses over here in a case which presents to you with a painful swelling in the upper part of the neck. So, the differential diagnosis of Bezold's abscess is acute upper jugular lymphadenopathy. It could be an abscess or mass in the lower part of parotid, infected brachial cyst, parapharyngeal abscess, and jugular vein thrombosis. So, this is all about Bezold's abscess. Next, let's move on to a fourth abscess, and that is Lux abscess, also known as Meatal abscess. Now, Lux abscess is a subperiosteal abscess, and this develops in the external auditory canal again as a complication of acute otitis media or acute mastoiditis. But important feature to remember here is there is no bony destruction of the mastoid cortex over here. And this is a very distinct feature that differentiates from all the other causes, other abscesses. The etiology here is a case of AOM or an acute mastoiditis. Here, the pus breaks through the bony wall between the antrum and the external bony meatus. The patient will present to you with a localized swelling in the posterior superior wall of the external auditory canal. It will be associated with tenderness, ear pain, otorrhea, a blocked sensation in the ear. But there will be no visible postauricular swelling and no pinna displacement. Diagnosis is mainly made through clinical diagnosis by performing an otoscopy. And when you see a CT scan, you'll see that there is a normal mastoid cortex and it will confirm the lack of any bony erosion over here. And coming to treatment of Lux abscess, we'll start the case on IV antibiotics. We'll perform an incision and drainage of abscess. Rarely you need to perform a mastoidectomy unless a mastoiditis develops. Next abscess to discuss here is Citelli's abscess. Now, what is Citelli's abscess? This is a deep neck abscess which results from spread of happening from a posterior spread of the pus in a case of acute mastoiditis into the occipital region via the posterior digastric groove and Citelli's tract. If you see in the image over here, how Citelli's abscess, the location is very different from that of postauricular abscess. Postauricular abscess happens just behind the pinna, whereas Citelli's abscess is more towards the occipital region. Now, there's a little confusion over here as well, where some authors have seen to be considering abscesses of the digastric triangle, which forms by tracking of pus from the mastoid tip as Citelli's abscess as well. Now, here in Citelli's abscess, the pus it starts to track posterior-inferiorly through the mastoid emissary vein or through the Citelli's tract. Citelli's tract is lying in the posterior aspect of the mastoid tip, and that leads to an abscess formation in the occipital or the retromastoid area. Coming to clinical features, the patient of Citelli's abscess will have swelling and tenderness in the posterior part of neck, below and behind the mastoid. It can end up in extending to the occipital region, and there will be symptoms of acute mastoiditis. This is usually a clinical diagnosis, and on performing a CT temporal bone and neck, we'll confirm the posterior tracking of the pus. Now, how do we treat these patients? We'll start them on IV antibiotics, perform an incision and drainage of abscess via posterior neck or occipital approach, and perform a cortical mastoidectomy. So that's all about Citelli's abscess. Last one that we know is the parapharyngeal or the retropharyngeal abscess. We won't be discussing this in details over here. I have 2 separate videos on parapharyngeal abscess and retropharyngeal abscess, which you can check out. But here, the parapharyngeal abscess or the retropharyngeal abscess, it usually results from infection of the peritubal cells because of the development of acute coalescent mastoiditis. So that's all about the 6 different abscesses in relation to mastoid that you need to know about. If you have any further questions on this, please note them down in the comment section and I'll get back to you.